So we next have our presentation on how to deliver model-informed precision dosing in the clinic. We're very lucky to have Assistant Professor Dr Iris Minichmayr from the Medical University of Vienna in Austria. I know people get Austria and Australia mixed up sometimes, but not the people in the room and not Iris, I'm sure. She holds a PhD in pharmacometrics from Freie Universität in Berlin. She worked with the Uppsala Pharmacometrics group in Sweden, and she's conducted several international research visits, including here at UQCCR. Main research focuses on PK/PD modelling of antimicrobials, translational prediction of antimicrobial effects, and model-informed precision dosing. Iris is on the editorial board of Clinical Pharmacotherapy and Therapeutics, and she's a founding member of the Precision Dosing Community of ASCEPT and vice chair of the Pharmacometrics Committee of IATDMCT. And that is another group, actually, quick shout out if anyone is interested in TDM and isn't following IATDMCT. They do a wonderful conference around the world each year, and they've got a podcast and they're a wonderful TDM organisation, not just antimicrobials, they do all TDM. All right, well, I'll stop sharing and feel free to take it away, and thank you so much for being here, Iris.
So thank you very much for the kind introduction and for the opportunity to speak at this year's annual Worldwide Precision Dosing Seminar. It's a particular pleasure because I had the chance to spend 2 research visits with Professor Roberts at UQCCR, and that definitely increased my interest in model-informed precision dosing. Today, I will discuss key considerations for delivering MIPD in the clinic, and I'll start by outlining the concept of MIPD. So MIPD involves the use of a pharmacometric model, such as a population PK/PD model, to predict individualized dosing for a patient. And this approach differs in several aspects from conventional therapeutic drug monitoring. So conventional TDM requires sampling at steady state. Typically, trough concentrations are measured and compared to a target range. And if the therapeutic range is missed, then the dose is adjusted and the process is repeated. MIPD can be used even before the initial dose is administered, and sampling can be performed at flexible time points even before steady state. MIPD uses specific target concentrations rather than ranges and provides a specific dosing recommendation. So MIPD requires a population PK model with specific clearance and other parameter values, along with associated variability. And to facilitate the use of these models, the model is implemented in a user-friendly software. MIPD can consider the entire dosing history and various patient characteristics simultaneously, such as, for example, body weight or sex and creatinine clearance. It's really crucial that all this information is documented accurately. So make sure to enter the actual time points for dosing and sampling, not the planned ones. And also include the actual dose given, dosing interval, and the infusion duration. Because if the provided information is incorrect, the predictions might also be incorrect. MIPD can be applied in 2 scenarios. Before the start of treatment, only patient information is available, but no drug measurements. Based on the model, predictions for the underlying population can be made, and a dosing regimen that has a high probability of reaching the target can be determined. During therapy, TDM samples become available, and drug concentrations can be measured in the patient at essentially any time point. The population prediction that represents the typical response is then balanced with the patient's observed response to make an individual prediction that moves closer to the PK parameters that can be computed using the Bayesian approach. And based on this, an individual dosing regimen can be determined that best meets the target. And this target doesn't have to be a trough value, but could also be a specific value of AUC or time over MIC, for example. So where does the model come from? So first, it can be newly developed based on the patient population of interest and clinical data collected from these patients. But alternatively, existing models can be extracted from the literature. And since there are often multiple population PK models available for the same drug, the key question is, which published model should we choose? Ideally, the target population and the population underlying the model are a perfect match, meaning that the model matches the target population in terms of patient characteristics, indications, and dosing regimens. The dataset should contain large numbers of high-quality samples, and the modeling should have been robust. But as real-world patient populations are pretty heterogeneous, it's very unlikely that a published model will perfectly match the intended population, and therefore it's advisable to evaluate which published model best predicts the drug concentrations in your target population. And details how to perform this model selection for MIPD have recently been summarized in a tutorial that I can really highly recommend. So once a model is selected, it can be implemented in various software tools. And conversely, different software providers offer decision support tools with different models. There are numerous MIPD software tools available. And for example, over 25 tools for antimicrobial dosing optimization have been detailed in 3 reviews of available programs. The software tools, they vary in their features. So most are based on population PK models. Some providers offer the option to implement new models, such as those that you have developed. Most tools support a priori predictions, as well as individual predictions using TDM. Some tools provide a summarized report of the results, others don't. And few tools can be integrated into electronic health records, which helps prevent manual data entry errors. And there are both commercial and non-commercial software tools available. A limited number of software programs are registered as medical devices with health regulators, and these devices are typically certified at lower levels of medical device classification. So registration does not necessarily guarantee the software's efficacy or accuracy. The software tool does not necessarily need to have all these features. It really depends on what is required and what is feasible in your workplace. We have explored MIPD workflows and software tools. So now the question is, for which drugs shall you use MIPD? And essentially, MIPD is recommended for the same drug for which traditional TDM is advised, namely drugs with a narrow therapeutic range where the goal is to prevent toxicity. But MIPD is also increasingly used for anti-infectives with a broad therapeutic range, such as beta-lactams, to ensure that adequate concentrations are achieved. And additionally, MIPD can be applied to drugs with non-linear pharmacokinetics. For MIPD to be effective, it's crucial that the relationship between exposure and response is understood, that a target is established, and a validated bioanalytical method is available. For critically ill patients, a position paper recommended the use of TDM and MIPD for aminoglycosides, beta-lactams, linezolid, teicoplanin, vancomycin, and voriconazole. But recommendations for MIPD can also be found in various guidelines. For example, the International Sepsis Guideline explicitly advocates PK/PD-based dosing and the use of dosing software. So now let's have a look at an example. There has been a consensus guideline suggesting the use of AUC-based dosing using MIPD instead of trough-based dosing to reduce nephrotoxicity. And the target AUC over MIC value is between 400 and 600. And I will show you a case study now using 2 different software tools. So the patient is 60 years old, has 90 kilos, a serum creatinine value of 0.9, and receives 2 grams vancomycin followed by 1,200 milligrams every 12 hours. And of note, this is a hypothetical example to show you the workflow. So on the left of the software TDMX, patient information can be entered, and the resulting concentration time profile of the typical patient in the population is shown. And below you see the dosing information and the PK parameters, like, for example, clearance. So now we enter the data of the patient, we select a model, and then we enter the serum creatinine value and the measured vancomycin concentration and the dosing regimen. And then we can have a look at the individual prediction in orange and at the individual PK parameters. So now, of course, we would like to individualize dosing, and we select a target of AUC over MIC of 500. And then a dose of 1,500 milligram is determined, so approximately 1,500, to reach an AUC of 500. So an AUC over MIC value if the MIC is 1. So exactly the same case study. How does it look in Insight RX? Again, we enter the patient information, the age, the weight, and information can be entered, and the panel in the middle contains the dosing information. On the right, we see the PK parameters, and below we can enter the TDM information. And now the current dosage regimen is displayed, and also alternative scenarios. For example, a dose increase by 25% to 1,500 milligram like before in TDMX. And Insight RX can also provide a report that summarizes all the relevant results. So a successful MIPD program requires interdisciplinary collaboration among various stakeholders that take over different tasks in the MIPD process. And these stakeholders include physicians that are, of course, crucial in making dosing decisions, clinical pharmacists who are essential for implementing and monitoring the MIPD service, nurses and phlebotomists that play key roles in sampling and documentation, lab experts that provide quantification of the drug. And IT staff are indispensable for integrating MIPD into electronic health records, and clinical pharmacometricians can help with the implementation and also the training of other healthcare professionals. Once an MIPD program is established in the clinic, monitoring various endpoints can help evaluate its success, and these metrics include efficacy surrogates such as exposure metrics, target attainment, time to target exposure, as well as safety endpoints like acute kidney injury. And the model performance can be assessed using measures of accuracy and precision. And additionally, evaluating the number and timing of samples can provide insights into the program's efficiency. It's important to demonstrate the outcomes of MIPD through prospective clinical studies, and we identified 29 prospective studies on TDM and MIPD for anti-infectives up to the year 2024, and we provided summary tables of these studies and their results into comprehensive reviews. MIPD is continually evolving, and the models are increasingly predicted not only PK and drug concentrations, but also drug effects and biomarkers. And for example, as you see here, you can measure neutrophils, and that serves as a surrogate for hematotoxicity, and that can also help to inform dosing recommendations. Other methodological advancements in the field include minimally invasive sampling techniques and machine learning methods, for example, for predicting drug exposure and dosing. So I thank you all for listening, and I hope I could give you an overview of the key aspects of MIPD in the clinic, and I'd be happy to answer any questions you have.
That was fantastic. What a wonderful overview. Does anyone have any questions in the room? Iris, can I ask you a quick question? Have you got a favourite drug that you've been using MIPD with, and how has it changed your practice?
I have to say, so I have only recently moved to this hospital here, so we are at the stage of setting up the MIPD service. So we're not at the point that it's running yet, but I feel So for example, in my hospital, beta lactams have been really extensively measured for approximately 2 years. And there's a lot of room for improvement. I think that's really an exciting field because not many hospitals in Austria, for example, measure measure beta lactams at this point, but our hospital does. So I think that will be very exciting.
Yeah, fantastic. It's obviously so helpful to have the MIPD outputs to give to prescribers, and it can really help illustrate your point so much nicer than just explaining it, I think, as well. The other thing that seems to be a bit of a theme again tonight is so many of our drugs are AUC based, and MIPD is just so useful for calculation of an AUC. So I think there's going to be a big role for MIPD across a number of drugs moving forward. I might let you off the hook unless there's any questions online. So there is one question actually, which is how common is MIPD in other countries? So that's probably a difficult question for you to answer. So I'll just say from the Australian context, I think we're starting to use MIPD for vancomycin. At the Royal Brisbane, where we do a lot of TDM, we have also used MIPD for the beta-lactams. And we're starting to use it a bit more for things like ciprofloxacin if we're trying to do an AUC. And we're looking at doing a trial of MIPD for voriconazole with some of my collaborators in the audience here. And I don't know if anyone else online wants to type in, or if anyone else in the room has any experience with MIPD at their sites. I think dalbavancin will be coming. Yeah, I think there's been a nice collaboration between Matthew, who presented, and one of our Italian, Matteo, our Italian friend who came in. They're actually going to make us an MIPD for dalbavancin, so that could be coming. Again, I can say from the UQCCR, but I suspect Michelle's already involved, that there is a plan for a project for gentamicin in neonates, but I don't think that will be necessarily news. But there's, again, if there's a model, you can use it. So there certainly is neonatal PKPD models for some of these drugs. But it's, you wouldn't want to be applying an adult or a CF or a critically ill or a heme adult model to the neonatal group, of course. And as you pointed out, the MIPD starts with a POP-PK model. And we've done it. I've got to call all time on questions. Thank you everyone for attending. Thank you to all the presenters. Thank you to everyone in the room and everyone online. Sorry I've kept you a little bit over. We will release the whole aminoglycoside talk. It is wonderful, and I'm sorry we couldn't get through it all tonight, but it's just wonderful that we could get through so much content. So thank you very much. Also, I'm so sorry, just in case you wanted to give feedback, it's such a gift to get feedback on these events. Please either feel free to email me if you don't want to do the whole survey, but it's just so wonderful to get feedback on these things. So please, if you have time, and give us your feedback. Okay, and then just to say there are more of these in the future. All right, thank you everyone, and keep an eye out for the recordings. Have a great rest of your day or night.